webinar. So let's start with today's session. Let me share my screen first. Yeah. Dr. Alok?
Yes, sir. It's visible.
Yes. So let's begin.
Yeah,
so
please.
The first half an hour would be basically on autism. What is autism? And the clinical features of autism, the management approaches in autism, and regarding what facilities are available for autistic kids in our country. So let's start with autism. So the autism spectrum disorder is a terminology which encompasses the previously known as autistic disorder or the classic autism, which was also called as Skinner's autism. Sometimes they were initially called as childhood disintegrative disorders or pervasive developmental disorder or Asperger's syndrome. Now, all these classifications have been grouped together into something called as autism spectrum disorder. So what are the factors which are associated with an increased risk or increased prevalence of autism? So there are parental risk factors and there are factors associated with the child. So in a parent, if a parent sibling has autism, that is considered as a high risk for your child to have autism. If there is advanced maternal age or advanced paternal age, if there are parental schizophrenia like psychosis or affective disorders, if there is use of sodium valproate in pregnancy in the mother, if there is abuse of alcohol during the first 3 months of pregnancy, which results in something called as fetal alcohol syndrome. So all these 5 are the risk factors for a child to have autism. Now, with your child, if your child has birth defects like CNS, central nervous system malformations or dysfunction like cerebral palsy, if there are some neurogenetic syndromes like Fragile X syndrome or phenylketonuria or Angelman syndrome, if there are some chromosomal disorders in your child, such as Down syndrome, if there is neonatal encephalopathy or epileptic encephalopathy, that is, if your child didn't cry after delivery, has got encephalopathy or has infantile spasms, or if your child has intellectual disabilities. So all these factors are at a high risk for a child to develop autism. So it's important to recognize ASD as early as possible. And hence we need to ask regarding the development of 3 important things. That is non-verbal and verbal communication, reciprocal social interaction, which includes eye contact, joint attention and social referencing, and sharing of interest or achievements. And the third is the representational or the pretend play skills. In the coming slides, I will be dealing with in detail what is joint attention, what is social referencing. So yes. So we need to know that the earliest symptoms are not the presence of abnormal ones, but the absence of normal ones. So we need to know what are the normal milestones, the developmental milestones for a child. And if those normal milestones are not present in a growing child, those are the red flags that your child may have autism. So if there is an absence of warm, joyful, reciprocating expressions, if your baby doesn't like to and fro babbling or jargoning, if your baby is excessively quiet and undependent, so these are the red flags that your child may have autism. If the parental concerns, if there are concerns with the parents about inconsistent hearing or unusual responsiveness, especially to name call. So name call is something that every child attains by 9 months and maximum by 12 months. So if your child doesn't respond to your name call by 12 months of age, then it is a red flag for autism and you need to get your child evaluated. Extremes of temperament and behavior ranging from marked irritability to alarming passivity. So these are both the ends of the spectrum, you could say. The child is excessively cranky, doesn't like to be touched, doesn't like to be swaddled, doesn't like to be held. Or the child is extremely happy-go-lucky, mixes very well with everyone. So these are red flags that your child may have autism. And the fourth is a very important thing. If there is at any point of time, if there is a regression of social skills or speech. By regression, I mean that your child has developed normally, has attained language milestones. The child is able to speak in 2 words or 3 words by 2 years, 3 years of age. And suddenly, all of a sudden, the child has stopped speaking whatever he used to speak earlier. This is a very important red flag that your child may have or may not have features of autism. So symptoms of autism, ASD stands for Autism Spectrum Disorder, henceforth in the presentation. So symptoms of ASD must be present in the early developmental period, but they may not be apparent until later. What I mean by this is that the ASD symptoms, they are present in the early development, less than 3 years of age. So, however, if there are minor features of autism, they might not be very much apparent till the social demands exceed the limited capacities. Hence, symptoms of ASD most commonly are recognized in the second year of life. However, symptoms in children with the least severe phenotypes of autism spectrum, that are the milder variants of autism spectrum, may not be apparent to parents or teachers until 4 to 6 years of age or later. So, what are the types of presentations in autism spectrum? Since it's a spectrum, it is applied clinically to this cohort of children, and there is a broad array of potential presentations. So, the first typical presentation is the child may present in the first year of life with delays in the core areas, that is social communication, social interaction, and if there are restricted or repetitive patterns of behavior, activities, and interest. Two, the second group may be the children who develop typically, maybe they develop all the milestones till 2 years or till 3 years, and then they have a plateau. They do not acquire further milestones. And the third category is the children who may show signs of frank regression after typical development. The child has milestones till 3 years or 4 years of age, and suddenly, all of a sudden, starts losing the milestones what the child has already achieved. So these are the three different types of presentations which we see in children with autism. So let's come to the core clinical features of autism. Impaired social communication and interaction. So impaired social communication, I would be dealing with non-verbal communication, verbal communication, and social relationships. The second core category is the restricted and the repetitive behavior, interest, and activities, which include the stereotyped behaviors and insistence on sameness. I will come to these points one by one in the coming slides. So, impaired social communication is a hallmark of autism spectrum disorder. We need to know that autism spectrum is not a disease, it's just a deviancy from the normal. So delays and deviations in language development are one of the most common presenting complaints of parents of children with autism spectrum. So this is also seen in our regular day-to-day practice when we ask the parents, didn't they notice earlier that the child was not responding to name call or the child was not socially active? That was not quite marked in the parents. They didn't feel the need for taking help at that point. But when the child didn't speak till 2 years, 3 years, that's the time when the parents decided to seek help. So in Indian population, especially, there is deviation in language development is the most common presenting complaint of parents of children with ASD. In addition to delayed or deviant language skills, children with ASD often lack the intent to communicate. So communication can be verbal as well as non-verbal communication. So the impairments in social communication are pervasive and sustained, though they may be present later in life than needed. So if there is lack of social and emotional reciprocity, lack of seeking to share enjoyment, interest, or achievement, impaired use of non-verbal behaviors to regulate social interaction, example, having a good eye contact, understanding the facial expressions, understanding the body gestures, failure to develop age-appropriate peer relationships. So what do I mean by social reciprocity? So individuals with autism spectrum disorders have deficits in social or emotional reciprocity. Younger children may be unaware of other children, including their own siblings. They may lack empathy for another's emotional perspective, that is unable to sense that another is in pain. They are not interested in imitating others or in bringing a novel object to a trusted individual to show. So these are the features of autism spectrum. Joint attention. Joint attention. So I think this point is clear. What do I mean by social reciprocity? So coming to the second point, it is joint attention. Joint attention is a spontaneous behavior in which an infant or a toddler tries to share interest, amusement, or apprehension about an object, the caretaker, or a playmate. So if a child and a parent are sitting together with a ball with a game, the child will look to and forth between the guardian and between the toy, and there is a eye contact which shuffles between the toy as well as the caretaker. or the playmate, which usually develops by 8 to 10 months of age. Or the child will point to an object usually by 14 to 16 months of age. For example, if an object is far away from the reach of the child would point to that object and look at the caretaker that he needs it, he wants it. So this is called as something proto-declarative pointing. So individuals with autism spectrum, they may lack or show reduced spontaneous seeking to share enjoyment, interest, or achievements with other people. That is, there is impaired joint attention or social preferences. Now coming to non-verbal communication. So individuals with autism spectrum have impaired ability to use and interpret non-verbal behaviors such as eye-to-eye gaze or the eye-to-eye contact, facial expression, gestures, and body postures. They have difficulty reading non-verbal emotional cues. During infancy, parents may notice that the baby resists cuddling, avoids eye contact, or fails to spread the arms in anticipation of being picked up, although these behaviors are not universal. Now, in the question and answers, I think in one of the questions, one of the parents had asked me why there is no eye contact. So, or when there is no eye contact in autism spectrum disorder. So the child does not have an eye contact because the child is not socially active. That's the reason why the child doesn't maintain an eye contact. Social relationships. Individuals with ASD fail to develop and maintain peer relationships appropriate to their developmental level. Younger children may have little or no interest in developing friendships. They prefer solitary play to social play, involving others in activities only as tools or mechanical aids, that is, using the hand of a parent to obtain a desired object without making eye contact. Now, in social relationships, the play skills are very important in a developing child. So, as we know that the play skills, they start right from 6 months to 7 months of age. So looking at the play skills, if a child is 3 years of age and is not interested in playing in a group or in sharing the toys with other group, or he sits in a group and plays plays alone, these are the red flags that a child may have features of autism. Now, older children may become more interested in social interaction, but lack understanding of what behavior is appropriate in one situation, but not another, or the need of others. Example, having little sense of boundaries, repeating memorized information regardless of its appropriateness. Now, the second core clinical feature in a child with autism is restricted and repetitive behavior. So restricted and repeated repetitive spectrum disorder. These include repeat and repetitive motor mannerisms, inflexible adherence to non-functional routines or rituals, preoccupation with stereotyped or restricted patterns of interest, and hyper or hyposensitivity to sensory input. So what do I mean by stereotyped behavior? So stereotyped and repetitive motor mannerisms. For example, on the tapping on the table, flapping the hands, spinning the toys. These are all motor mannerisms. Complex whole body movements like hand or finger flapping, twisting, rocking, swaying, dipping, walking on tiptoe, toe walking, lining up exact number of playthings in the same manner in a stereotyped ritual. Must think kids with autism, they often have a habit of lining up things along the edge of the table. So this is a type of a stereotyped and repetitive mannerism. Other stereotyped behaviors may be seen like echolalia. Echolalia stands for if I say something to a child, the child would repeat it again and again. And idiosyncratic phrases. The child will keep on repeating some phrases from seen from the cartoon, from the TV, repeatedly. So these are also stereotyped behaviors. Insistence on sameness. Apparently inflexible adherence to specific non-functional routines or rituals is a characteristic of autism spectrum. The insistence on sameness may manifest with distress at small changes in routines and difficulty with transitions. So kids with autism, they do not like change. So if you try to bring a change in their behavior, they would be tempered, there would be tantrums, they would resist the change. So individuals with ASD have significant difficulty with change and may need the same routine identically every day. These may manifest during various aspects of daily life, such as the need to always eat particular food in a specific order, or to follow the same route from one place to another without deviation, or to wear the same color of clothes or the same type of clothes or a cloth with same texture or material. The play of children with ASD may appear to be scripted, mimicking of what has been seen on a television. Sensory perception. Sensory processing abilities are aberrant in almost half to 99% of individuals with ASD. So the aberrant responses may include over-responsiveness or under-responsiveness and paradoxical response to environmental stimuli. So what are the examples? Resistance to being touched or increased sensitivity to certain kinds of touch. Light touch may be experienced as painful, whereas deep pressure may provide a sense of calm. This may include resistance to the feel of certain clothing textures or colors next to the skin. Apparent indifference to pain. Strong preferences for or compulsive touching of certain textures and strong aversions to others. Hypersensitivity to certain frequencies or types of sound. Example, distant fire engines with lack of response to sounds close by or sounds that could startle other children. A pressure cooker in your kitchen, the child is not startled. Preoccupations with sniffing or licking non-food objects. Preoccupations with edges, spinning of objects or shiny surfaces, looking constantly at the lights or odors. Visual inspection of objects out of the corner of the eye. So if your child has a habit of looking at the corner gaze, which is what we call it, from the corner of the eyes, it's a red flag of autism. Refusal to eat foods with certain tastes or textures, or eating only foods with certain tastes and textures. Dietary obsessions may be associated with GI symptoms. Example, weight abnormalities, abnormal stool patterns. So eating difficulty is a very important complaint of a parent with autism. Now coming to language impairment. So if there is a delay in or total lack of development of spoken language, is a characteristic feature of autism spectrum. This is not accompanied by an attempt to compensate through alternative modes of communication such as gestures or mimes. In most individuals, receptive language is delayed even more than the expressive language. So receptive language, there are two types of languages. One is the receptive communication and the expressive communication. Receptive communication is what the child understands, and expressive communication is what the child is able to speak and express. So the children may not respond to the calling of their names. Concerns regarding hearing impairment may be representing complaint. However, it may be that the child is having signs of autism. Children with autism spectrum may be unable to understand simple questions or simple directions. There is very poor autism. They do not engage in simple imitation games of infancy and have relatively normal understanding of phonological aspects, grammar, and some aspects of meanings of language. However, they may have difficulty gaining their listener's perspective, realizing meaningful implications of what is said, and understanding and conveying shades of the meaning. They may have a difficulty appreciating humor or sarcasm. Regression. Now coming to regression of milestones, which was the third point in the previous slides. So approximately 1/4 to 1/3 of children with autism spectrum achieve early language milestones, but then later they have regression of language, communication, and social skills between 15 to 24 months of age. Very important that it may be associated with a developmental delay or there is an atypical development. Regression of skills is an important characteristic of autism spectrum. Attribution of regression to stressors such as birth of a new sibling or moving to a new home or a new school, it may delay the diagnosis of autism spectrum. Now, the other less important clinical features seen in the kids with autism spectrum are motor deficits, which include abnormal gait, clumsiness, toe walking, or other abnormal motor signs such as decreased tone of the muscles or hypotonia. Kids with autism may also have intellectual impairment, so cognitive skills of individuals with autism spectrum are usually uneven, regardless of the general level of intelligence. So, in brief, these are the clinical features of autism spectrum, and I would like all the parents, all the participants in the seminar to know about these basic clinical features in autism so that they could identify their kids if they have autism and seek early help. Coming to the management of autism, so I would not go into the details of each therapy. It's just an overview of the domains of management. So the autism management is divided into the following categories. So the core features are the first thing which we stress upon, which includes social communication, social interaction, and trying to decrease the restricted and the repetitive patterns. Then we deal with the associated features which may be seen in some kids with autism, like features. 15 to 30% of children with autism have disorder or anxiety. Then we deal with education, which includes inclusion, curriculum, and provisions. Then adolescence, which involves sexuality and vocation. So, in basic, the principles of management are intervention should begin as early as possible. Diagnosis is not necessary intervention. Intervention should target the core features of autism. So, deficit in social communication and interaction, and trying based and structured. There should be a team approach in managing a child with autism through interdisciplinary teams. So the team includes pediatrician, developmental pediatrician, child neurologist or child psychiatrist, clinical psychologist, occupational therapist, speech and language therapist, special educator, and social worker. So these are the specific interventional models which are commonly used in our country for children with ASD. So many centers use a combination of various therapies. So we have behavioral therapies like ABA analysis, applied behavioral analysis, then the structured teaching. Example, the treatment and education of autistic and related communication handicapped children, the TEACH criteria, then developmental or relationship-based, that is the floor time, and integrative programs using a combination of strategies within the treatment program, like the SCORTS, the social communication, emotional regulation, and the transitional support SCORTS program. What is ideal interventional program? It is based upon the child's chronological age, developmental level, specific strengths and weaknesses, and the family needs. So this is if we're starting any interventional program, we need to focus upon the following 4 points and then formulate an intervention program which is specific for that child. A minimal intensity intervention program should be minimum 25 hours per week. The characteristics of the program are: it is a 1-to-1 or 1:2 program, individualized programming for each child. There's an interdisciplinary team that documents evaluation and intervention, each professional with special expertise in working with children with autism, minimum of 25 hours per week of services, ongoing program evaluation and adjustment, and a curriculum emphasizing attention, imitation, communication, play, and social interaction, and family involvement. So, to manage the core and the associated features, the goal should include enhancing eye contact, should be increased social orientation, improvement of non-verbal and verbal communication, reduction in repetitive and restricted behaviors, activities, interest, sensory issues, hyperactivity, improve the sitting tolerance, improve the joint attention, and improve the social motor and behavioral capabilities. Now, parents also have a very important role to play in early intervention. So parent education and home component are the important but not superior to individual intervention for each child. Parent education and home components are more likely to be effective if a part of a multidisciplinary intervention. Acute involvement of families and caregivers as a co-therapist is desirable, but only with appropriate supervision, training, and monitoring. Parents should help set goals and priorities for their child's treatment and teach or reinforce their child's new skill at home and in the community. So it is cost effective and increases the sense of empowerment on the part of parents and caregivers. So what I stress upon is that apart from the therapist, the parents have a very important role in managing in the therapy sessions in managing a child with autism. Now coming to there are many parents in this group who have kids of 12 years, 14 years of age who have asked me many questions. So older individuals with ASD should also be actively engaged in comprehensive interventions. Although more research is needed to better define the appropriate models of service delivery and the number of hours per week. Individuals with limited verbal languages or those who do not respond to multiple interventions aimed at providing communication should be offered the opportunity to use a mode of communication called as PECS, that is Picture Exchange Communication System. So one of the questions asked was, what do I do if a child isn't communicated? 14 years, my child has autism. So I would suggest that PECS is a very innovative and a very time-tested communication model which has been used for children with autism. Augmentative and alternative communication interventions such as computers or other devices should be considered if the PECS is unsuccessful. Sexuality in adolescent kids with autism, specialized sex education programs with a social interaction emphasis should be considered. And children with autistic traits, especially those with limited social interest and social regulation problems, have a higher risk to develop psychosocial problems, albeit mild in early adolescence, as reported by many parents. Now coming to the final few slides of the seminar. So what are the factors associated with positive outcomes? So presence of joint attention, functional play skills, higher cognitive abilities, mild severity of autism spectrum symptoms, early identification, involvement in intervention, and a move towards inclusion with typical peers. These are the factors associated with positive outcomes. What are the factors associated with less favorable outcomes? So if there is lack of joint attention by 4 years of age or lack of functional speech by 5 years of age, if the IQ is less than 70%, if there are other comorbid conditions like seizures, ADHD, ID, intellectual disability, or other neurodevelopmental conditions, if there are severe autism spectrum disorder symptoms at the time of presentation, these are the factors which are associated with less favorable outcomes. To inform the parents in today's webinar, there are many schemes available for children with autism. Like the National Trust has various schemes like the Maya scheme for insurance, aspirations for early intervention, the Gyan Prabha scheme for scholarship. The details can be found at nationaltrust.co.in. Also, children with autism, they have a UDID card made, and that allows them for certain monetary benefits for children with autism. Also, there are concessions in railway tickets and the hotel stays for children with autism. So summary, autism spectrum disorder is a complex condition with widely varying clinical manifestations, thus requiring evaluation and interventions by a range of professionals working in coordination. Behavioral and environmental interventions are the key to optimal outcomes in conjunction with medications for specific symptoms. Parent involvement during intervention is important to sustain therapeutic gains. So this was in short regarding what is autism. So coming now to the questions in autism. Alok?
Yes, sir. Thank you so much, Dr. Abhijit, for giving such a wonderful presentation. And it has given us a very
previously and yeah, and then later we can take up the questions from the chat box, right?
Yes, we can start taking up the questions, or we can open the forum also. So if somebody wants to ask a specific question, you can write it in the chat box, or you can speak up as well. Unmute your mic and speak up one by one. Both the things can be done.
Yeah, so first let me cover the questions which I've already received from the parents. Okay.
Yeah, please.
Yeah. So the first question is, my son is 11 months old and does not respond to name call. Does he have autism? Now, not responding to name does not necessarily mean autism. So on an average, the child will start responding to their name by the age of 8 to 9 months. And by their first birthday, the child should respond to name call. If a child doesn't respond to name call by 12 months, it is a red flag that a child might have autism, probably autism, or some kind of developmental delay or a hearing loss. So it does not necessarily mean that if a child is not responding to name call by 11 months, he has autism. So you need to visit and need to see for other signs of autism, such as lack of social interaction, no play skills, any kind of stereotypic behavior. So that will all point towards that your child has autism. The second question is, my elder son is diagnosed with autism at 3 years of age and my younger son is going to turn 3 in a couple of months. When should I be worried? So we need to understand that autism is something which is The cause is not correct, purely no. It has a genetic component as well as environmental. By what do I mean by genetic component is that while having a child with autism, there is if your first child is having autism, there is a 15% risk that your second child may also have autism. And boys are more at risk than girls to develop autism. So, in case your child, your second child, your first child has autism, your second child is going to 3. So, in case your second child has no social skills, lack of language or regression of language, or there is a stereotypical behavior, insistence on sameness, then these are the features that your second child may have autism. The third question is, my child is 2.5 years old and is obsessed with certain routines such as sleeping on the same bed sheet, wearing the same shoe color, but he speaks in sentences and uses gestures to convey his needs. So, should I be worried? Now we need to understand that repetitive behavior and obsessions may be normal in a young child, but they are expected to fade away with age. However, if these symptoms they persist and if they increase in intensity, there is a other entity called as your child may have autism spectrum, or your child may have other neurodevelopmental issues such as attention deficit hyperactive disorder, or it may be a high functioning autism. So in children with something called as high functioning autism, the child may speak in sentences, sometimes may use gestures, but will have deficits in social communication skill. So you should look for other signs of autism, such as flapping, hand flapping movements, repetitive behaviors, having no social interaction, and you need to visit your pediatrician to confirm the diagnosis. My daughter was diagnosed with autism at 4 years of age and now has a lot of behavioral issues. Would an early diagnosis help? So, to be frank, 5 years earlier, autism was usually diagnosed at 3 years and 5 years of age, at 3 to 4 years of age. And currently, with the increased awareness of autism, it is being diagnosed as early as 2 years to 3 years of age. So, purpose of diagnosing early, yes, I would say that early diagnosis would have helped your child. The purpose would be early diagnosis allows these children to develop and enhance their skill to reach the full potential. And the young brain has something called as plasticity. So by between 1 to 3 years of age, the brain, newborn baby's brain has a feature called as plasticity, which is the core concept used in the various models of therapy. So, with the repeated use of activities, there is something called as pruning or the destruction of unwanted connections in the brain, neural networking, which helps the child to have better outcomes. So, definitely early diagnosis and early intervention would have helped your child if therapy would have been started a bit earlier. The next question is, my son has normal speech and development up to 3 years and had fever for 2 days. Suddenly, post recovery, my son started speaking less. Is it a sign of autism? I would say yes, it may be autism. So now, since your child had fever after 3 years at 3 years of age, and post recovery, child started speaking less. So this may indicate a regression in the language milestone, or it may be a part of some other illness, like the fever might be because of some infection in the ear, which has caused a partial or total hearing loss, and that's the reason that your child has started speaking this. So you need to get your child evaluated first, do a hearing test to see for hearing in the both the ears, and see for other signs of autism, which I mentioned in the previous slides. Are childhood vaccines responsible for causing autism? No, childhood vaccines are not responsible for causing autism. However, previously it was understood that few vaccines may have caused autism, but it is proven wrong by the latest research. In fact, childhood vaccines are very important as they protect and prevent your child from getting the common infectious disease. So please do vaccinate your child for as per the vaccination schedule. My child is recently diagnosed with autism. Is he likely to suffer from other medical issues as well? So, yes, most likely autism is also associated with other comorbid conditions like anxiety, ADHD, intellectual disability, learning issues. So, seizures may also be present in autism. So, yes, there is a chance that there might be other medical issues along with autism in your child. My elder child was diagnosed with autism at 3 years of age, and I'm 5 months pregnant. What are the chances of autism in my second child? As I previously mentioned, that autism has a genetic component, and there is always a 15% chance if your first sibling is having first child is having autism, then there is a 15% risk that your second child may have autism. And also, if it is a male, it is a 3 to 4 times more risk than a female child in developing in having autism. My child has features of autism, but no diagnosis has been made. What should I do next? So a diagnosis, I would say, is not very important in autism. It is the developmental intervention which should be designed and executed early as per the needs of your child, which is really important. So formal diagnosis can go side by side um, with the therapy. So initiating therapy is what is more important if your child is having features of autism. My child is autistic and sometimes very hyperactive. And many parents have asked me this question: how to decrease hyperactivity in my kid? So, Dr. Alok, would you like to take this question?
Yeah, definitely. There are various practices by which we can decrease this hyperactivity. First thing is we need to understand their behavior pattern and when they become hyperactive. It is we need to understand their condition. It is called regularization and deregularization. So there are certain points when they are not able to express themselves, they become too hyperactive. There are some certain points which situation is not favoring them, they become hyperactive because they are not able to communicate to us like the other regular kids do. So we need to avoid such situations. That is one thing, and we need to calm them down. At times we see that the child behave in a very different way once they are in some crowded area. So we need to, with practice, we need to, as sir has already mentioned, that we need to make it a daily routine and slowly and gradually. So the parent need to have a lot of patience in order to decreasing the hyperactivity and cooling them down. It can happen only with the behavioral practices, and it can happen only with the parents intervention, though the therapist's role is important. But here the parents also need to keep the patience and keep repeating the things. Like this environment, you need to keep repeating. Suppose before taking them to a school, if you want to do the if before taking them to any school or any other place, wherever like in a crowded place, we need to practice with 2 people, 3 people, 4 people gradually, and after a month it would be a situation when the child will feel comfortable with others. Yes sir, please.
Yes. So Dr. Alok has clearly said that the hyperactivity is always due to the inability of the child to express himself, or there is impairment in the social behavior or social communication. So we need to focus on these domains, and we need to know what has triggered your child to become hyperactive, and we need to avoid these factors to decrease the hyperactivity. Now, what type of therapies?
सर एक क्वेश्चन था ये रिगार्डिंग हाइपर एक्टिविटी, मतलब ये मेरा बच्चा है मोर देन 6 ईयर का हो गया है और ऑटिज्म स्पेक्ट्रम डिसऑर्डर भी है और मतलब एडीएचडी भी है। तो हम लोग तो मतलब बहुत सारा प्रैक्टिस कर रहे हैं स्टार्टिंग से ही, मतलब कुछ मेडिकल साइंस में कुछ मेडिसिन भी हम लोग दे सकते हैं क्या, या मतलब कुछ इस तरह का फैसिलिटी है क्या कि उसका हाइपर एक्टिविटी को कुछ कम किया जा सके?
Yeah, so I think what so he's trying to ask is that apart from behavioral therapy, is there pharmacological therapy to decrease hyperactivity? Am I right?
हम लोग चाहे मतलब कुछ मेडिसिन के थ्रू भी मतलब इस तरह का कुछ
Yes.
फैसिलिटी है क्या कि मतलब हम लोग उसके हाइपर एक्टिविटी को कुछ कम कर सके, क्योंकि
Yes,
हम लोग अपना
definitely.
एफर्ट लगा रहे हैं लेकिन
Yes,
एक हद
definitely.
तक से, हाँ, तो मतलब यही जानना चाह रहे हैं कि कुछ मेडिसिन इस
Yes,
तरह से है कि जो कि डिक्रीज कर सके उसके हाइपर एक्टिविटी को।
definitely. There are medicines. There are few pharmacological medications available which can be used. I'm not saying to be used in every child. If with behavioral therapy, if the behavioral therapy is executed properly, and as you said, आप घर पे कर रहे हो and all, और सभी मतलब बहुत साल से चल रहा है, इसके बावजूद भी हाइपर एक्टिविटी कंट्रोल नहीं हो पा रहा है, in that case we can think there are pharmacological medicines available like methylphenidate, atomoxetine, which may provide help in children with ADHD. But one thing we need to understand that these medicines also have their side effects, so it should be prescribed by a pediatrician, and the dosage should be given by the parent or the caretaker. Because you cannot because the dosage, because these are very what do you say, these medicines have side effects if it is taken in a wrong dosage. Yeah. So
Hi, doctor.
apart from ADHD with autism, seizures are also a very important comorbidity in a child with autism. So if the child is having seizures, in that case these medications are contraindicated, they are not to be given.
Hi, Dr. Abhijit.
Yeah.
With your permission, may I just add to this?
Yes, please.
Okay, hi. I think Mr. Jay Prakash ji has posed this question that the child is very hyperactive. So now we need to channelize the hyperactivity of these children, because as they keep growing, the energy level also keep growing in them. So how do you channelize this? Because I am
उसका सारा एनर्जी लेवल जो है अदर वर्क में ही चला जाता है।
तो सर
हम
मैं भी ऑटिस्टिक बच्चों को साथ काम करती हूँ, मैं स्पेशल एजुकेटर हूँ, तो मेरे पास में भी एक बच्चा आया था, तो हमने क्या किया, वो थोड़ा सिवियर था, हमने उसको स्पोर्ट्स एक्टिविटी की तरफ चैनलाइज कर दिया। तो उसकी जो हाइपर एक्टिविटी थी, मेडिकेशन क्या करेगी, मेडिकेशन उनको काम डाउन कर देती है बिकॉज वो न्यूरोलॉजिकली अफेक्ट करती है, लेकिन आपकी वो जैसे ही मेडिसिन का जो असर होता है, जैसे ही वो खत्म होगा, उसकी एनर्जी लेवल फिर से हाई हो जाएगा। सो दिस व्हाट आई डोंट रेकमेंड। सो मैंने क्या किया, उसको स्पोर्ट्स एक्टिविटीज की तरफ चैनलाइज किया। अब जैसे कि डॉक्टर अभिजीत ने बात किया था प्लास्टिसिटी, सो आई हैव स्टडीड अबाउट न्यूरोप्लास्टिसिटी। न्यूरो मीन्स ब्रेन, प्लास्टिसिटी मीन्स मोल्डेबल। सो अगर हमारे ब्रेन का कोई भी एक पार्ट फंक्शन नहीं कर रहा है, हम एक दूसरे पार्ट को हम लोग पॉलिश कर सकते हैं कि वो उसका काम कर सके। तो न्यूरोप्लास्टिसिटी, हम वो दूसरे जो पार्ट होता है ब्रेन का, उसमें हम एक पाथ बना देते हैं। तो आप अपने बच्चे को स्पोर्ट्स एक्टिविटीज में डालिए जो स्ट्रक्चर्ड हो। ऐसा नहीं है कि वो कुछ भी कर रहा है, जैसे म्यूजिक कैसे होता है, म्यूजिक चल रहा है और बच्चे कैसे भी डांस कर रहे हैं, वैसा नहीं। जैसे साइकिलिंग हो गया, स्विमिंग हो गया, एक स्ट्रक्चर्ड प्ले हो गया। सो अगर आप वो अपने बच्चे को एक स्ट्रक्चर्ड स्पोर्ट्स में डालेंगे विद अ प्रॉपर ट्रेनिंग, तो उसकी जो हाइपर एक्टिविटी है वो चैनलाइज होगी and he will definitely improve better. Thank you, Dr. Abhijit. This is my personal experience, so it may help someone,
Yeah, definitely.
Or I'll add on some point here that at times we need to take the support of these medication. वो इसलिए लेना पड़ता है even while doing the behavior therapy or any other kind of therapy, speech or anything, क्योंकि वो बच्चा अगर पूरा टाइम हाइपर एक्टिव है, एनर्जी लेवल बहुत हाई है, तो वो थेरेपी पे भी कॉन्सेंट्रेट नहीं कर पाता है। सो एट टाइम विद द हेल्प ऑफ पीडियाट्रिशियंस we also take the support of some of the medicines so that बच्चे को थोड़ा सा काम डाउन करके और फिर उसके साथ हम behavioral therapies या other therapies, speech etc. हम कर सकते हैं। But that should be, as Dr. Abhijit has said it should always be in consultation with a pediatrician. Yeah, please, Dr. Abhijit, can we take the further questions? I think there's so many questions on the chat board also, sir, so if we can start taking them also.
Yes, definitely. So regarding some parents are asking about sensory integration therapy, is it helpful in children with autism? So if your child is having difficulties in sensory interaction, appropriate reception, assimilation and modulation of various senses, it can create behavioral impairments in child with autism. So if a therapist is well trained to deliver sensory integration therapy, then yes, it is very helpful for a child with autism having sensory issues. How to potty train a child with autism? I would say it is with behavioral therapy, occupational therapy, and personally at home, the parents can use something called as visual cards to help potty train your child. A routine has to be maintained. You need to show cue cards to your child, and you need to potty train your child. What are the opportunities available for adults with autism, and are there any government guidelines? Yes, I mentioned in the previous slides regarding various schemes available for autism. So all the parents with autism need to register themselves and have a UDID card, that is unique disability identification number, for your child who's having autism, and you can then avail the various schemes in the government setup for your child with autism. So let's go to the chat box and take a few questions. Yeah, so the first question is by Mrs. Harsha. My 7-year child is autistic. He speaks only needed, but repetitive behavior and sensory issues. How to solve the issue? How to teach him communicate? Yes, Dr. Alok, you would like to take this question?
Yeah, definitely. So this child, as you say, that child is 7 years old and he speaks only needed. So there might be some issues with the oriomotor exercise we need to do. There might be some issues with the cheek muscles. So the speech therapist or behavior and behavior therapist can work out on that. So the first and foremost thing is we need to do the assessments. We need to find out why the child is not communicative. That is first thing we need to do. There are many factors for it. Second thing is the behavior therapy. Of course, behavior therapy is recommended for this child. So that has to go on, because communication and language is a part which has all three factors. The OT and oriomotor training comes the part of OT and the speech. And then the third thing comes is behavior therapy. So all three things might be required for here. Yes, sir.
Yes. The second question is from Mrs. Nita Naik, that I think a child is diagnosed with autism spectrum, 2 years and 1 month old. And what's the next step? What therapy to start with? And is it necessary to consult a neurologist if the child is diagnosed with autism? So as I said, that diagnosis is not important in autism. If you feel that your child is having features of autism spectrum, as I mentioned previously, therapy is important. You need to get your child assessed by a pediatrician, by a child psychologist, and therapy needs to be started immediately. What therapy to start with, it depends on case-to-case basis, based on your child, based on his what domains are affected, what are his strengths, what are the family strengths. So based on that plan, individualized plan is made for your child, and accordingly therapy is formulated and delivered. I don't think it is necessary to consult a neurologist if a child is diagnosed with autism, but we also need to know that kids with autism might have seizures or epilepsy as a comorbid condition. So in that case, a neurologist intervention becomes really important. Yes, Dr. Alok, would you like to add on something?
Yes, I will add on here that what happens here is that parents looking at each other, usually they feel like, okay, I want to do the IQ testing of my child. I want to do this test, that test. See, frankly speaking, these tests are important. I am not against them. They are important. But what are we going to achieve? What is the outcome of the test? Whether the test is really needed, necessary, then only we should go for it. Otherwise, every individual child is different. So we as therapists or the doctors, pediatricians, they need to assess, developmental pediatricians, they need to assess every child on the patterns of his behavior, on the patterns of his issues, what he is facing. And on that basis, we design the therapies. So these tests are very standardized tests, and they even if two people are doing the same test, the results may vary. So it is on individual observation which is more important than any kind of testing. That's what is my personal belief. Yes, sir, please.
Yeah, so the next question is by Mrs. Priyanka Chatterjee. My daughter is 3 years, 6 months. She's non-verbal, case of global developmental delay on anticonvulsant, and she has epilepsy. She has stereotypical movements. No therapy has started yet.
a formal assessment is not yet complete due to COVID situation. What should I do? I am a full-time working mom, and due to her excessive crying and shouting tantrums, she is learning nothing. Even she is not able to learn her toilet training. Now, it's a very good question which is faced by most of the parents, working parents. Because of the COVID situation, it's become difficult to visit a center because of COVID restrictions. So there are many centers which provide online consultations. Online consultations are provided by almost all the centers. Even we at JKP Health Center, we provide online consultations. We diagnose your child via the online platform. You can send some videos to us. We can see the videos and then give our impression. So I don't think that COVID situation would be a reason to not to start therapy. I would suggest as soon as possible you can enroll yourself in any of the online programs available and start therapy immediately. Now, in your child specifically, since there is global developmental delay, your child might need also physiotherapy apart from behavioral therapy and occupational therapy. As she needs to be mobile, she needs to be ambulatory. As at the same time, she needs to be independent in her daily living activities. So I think this would be the best approach for your child, Mrs. Priyanka. Dr. Alok, would you like to add on this?
I have one point to add here. There is one question about this also, that about child's tantrums, and here also that the child is crying and tantrums are increasing. So one thing is, every parent should understand that word tantrum itself is not the correct word. It is not child's tantrum. I would call it as child's frustration which he is releasing. So, as I was talking about the regularization and deregularization, see, every child is wired in a brain. Every child's brain is wired in a different way. So, when he is not able to, just imagine the situation for you, on yourself. You are very thirsty, but you are not able to express. You're not able to say it to somebody that I'm thirsty and you want water, or if you want food and you are hungry, but you cannot express. So understand the child. Why the tantrums, the word tantrum which we are using, I will say the behavior, that behavior, why it is increasing is because he is growing with the age, he or she, and not able to express what exactly they want or how exactly they are feeling. And when they are not able to express, they cry or they flap their hands, or they do many such sort of behaviors. So we need to understand, so that as a mother or as a father, as a parent, we need to understand the situation of the child and read the behavior pattern, where exactly his behavior is going hyper, and try to avoid that situation, or slowly make him accustomed to that situation. If it is a regular situation which he has to face in his life, so slowly make him accustomed instead of just putting him there on one day. That's all. Yes, sir, please, we can go to the next question.
Yes, so the next question is from Mrs. Anu. My child is autism, 5 years old, not able to communicate a single word, taking speech therapy since last 3 years, but not able to communicate till now. Will he speak or not? Sounds are there. So, yeah, so what I would say is that every therapy what you take, Dr. Alok, would you like to take this question?
Yeah, definitely. See, we need to understand first that what are the reasons why he is not saying even a single word. Sound is there, so why he is not saying? So only the speech therapy might not help at times if his tongue muscles are weaker, if his cheek muscles are weaker. Maybe he is not opening the mouth. Because of that reason, he is not able to twist the tongue. He has a thick tongue. So we need to understand first. So the assessment is very important here, and assessment has to be done by all three parts. So like, it's not just the speech assessment. It could be the OT assessment is also required here. So I think personally we can assess this child, and then only we can find out the reason why he is not able to speak. Yes, sir, please.
Yeah, I would like to add on this point. Is that any intervention which we give to a child, it is designed to deliver an outcome in terms of developmental improvements as far as possible in a specified time frame. So I think you need to discuss this concern with your therapist regarding a written plan, written outcome, and what would be other interventional models. As the as since 3 years of therapy, speech therapy, and there is no speech as of now. So I think some alternative therapies need to be, or alternative plans need to be tried upon. So this is important. If it is not working, then you need to go back to your therapist. You need to discuss what is going wrong. That's what I personally feel. What do you think, Dr. Alok?
Yeah, that's
apart from it's a case-to-case basis, yes, no doubt. But since it is 3 years that a child has not the therapist.
Yeah, because the age is growing, so we also need to keep that factor in mind, that this is the development age, and if we lose on this age, then it becomes difficult to cope up later. So it's better to discuss with the therapist, or try some alternate therapy, or change the pattern, change the therapy strategies. What exactly going wrong, we need to find out that.
Yes. From Ruth Da Costa. So is it necessary to follow PICS if the child doesn't follow the cues but has need-based 1 or 2 word speech? My autistic child has been going for therapy since 2017. With unavoidable breaks in between. So she will be 7 in December. So I assume that since 5 years she was diagnosed at autism. There is remarked improvement in her skills, but her attention span is very poor. Using PECS is quite difficult because we have a younger child who's always meddling around. Just wanted to get an opinion if PECS can be avoided if the child knows and understands instructions and requests. Yes, PECS can be avoided if your child understands instructions and requests. But is able, we would need to actually assess this child to comment further. What do you think, Dr. Alok?
Yeah, that's correct, sir. It can be avoided, but I think need to take call on case by case basis. Without assessment, proper assessment, we cannot just comment generally.
Yes, correct. From Guni Garg. So I would like to know which center, Ruth Da Costa, your child is enrolled in. Yeah, from Guni, 7-year-old. And he was diagnosed as ADHD, but now he has problems like repetition of sentences, words, which he had heard 2 to 3 days back, or he has seen in the past. Yes, I think Pramila Agarwal, yeah, she can take this question.
So, sir, can you please repeat that?
Yeah. So my son is 7 years old and is diagnosed with ADHD, but now he has problems like echolalia. He has problems of echolalia basically.
So, sir, if the child is 7 years old and, I think he's applicable for a formal diagnosis. So anything that, we cannot directly say that what is the concern. So the child need to go to a developmental pediatrician and need to have a psychoeducational assessment. Because only having one, echolalia is very common, when it comes to ASD. This is the one, like not giving eye contact and echolalia. These are the very prominent, things that we say are associated with ASD. But, I never scared the parents and give a diagnosis unless it comes from a clinical psychologist, from a specialist. So I think he's already 7 years old and they should go for a formal diagnosis, sir. And then we can take it forward with the, what therapies the child will, need once we get the diagnostic impressions. I hope this helps.
I completely agree with Pramila ma'am that yes, we need to go for a formal assessment, then only we can comment on this. Because labeling a child is a very it's a very it should be the last thing to do. Yeah. Without a proper assessment, we cannot say anything here.
Yes. So could I answer your question? You asked me which centers I take my daughter to.
Yes, I saw it on the chat. It's DIC Margao, right?
And I also I would go to a PNRC also.
Bangalore, GMC.
agency, but we cannot. I have expressed my inability to use specs because of my child, and because it becomes quite difficult. So
Yes.
she, but I'm not. I mean, not about the centers that I'm going to, but whenever I have a word or whenever I any other this thing, they always say use specs. So I just wanted a confirm. I mean, an opinion whether it is really this thing when this child can, if she follows instructions. And if I ask her to pick up something or get it, she does all those things. So would that hamper? Is it too late to start PECs now, sir?
No, it is not late to start PECs. In fact, PECs is used when other communication models have failed. So I would not say it is too late to start PECs. Since you are enrolled in DIC Margao, I think we can have an appointment with you, and we can discuss further.
Sure, doctor. Sure.
Yeah,
thank
so
you.
I think Dr. Anar would be your therapist, right?
Yes.
Dr.
And
Anar
I
is your therapist, right?
Going for special education with Renu.
Renu and
my
Renu.
daughter, yes, Renu. Yes. Yeah, thank you, doctor. Thank you.
Yeah, sure. The next question is, I've been reading that autism can present differently in girls due to coping skills such as masking and mimicking other girls, and even quietly holding it together at school, but then melting down at home. Have you observed differences in girls and boys? If so, what are some keys to diagnosing and treating girls? Are there any conditions besides autism that cause high social anxiety and sensory issues? As far as autism is concerned, there is no differences in presentation between boys and girls. Only the rate of incidence in the boys is 3 times more as compared to that of girls. Now, there are other conditions. It's not besides autism. They have few features of autism, like decreased social interaction, high anxiety, which you call a social anxiety disorder. So in that cases, the child is extremely anxious to unknown people, to unknown environment, to unfamiliar environment, or there is something that the child is absolutely normal, has no features of autism, but the features mimic due to sensory issues. So there is a sensory processing disorder. So these are completely different entities from autism. So yes, anything else, Dr. Alok, would you like to add on this?
No, nothing, sir. That's all. I agree with it. Nothing else to be.
Yes. The next question is from Mr. Parmeshwaran. How would be the learning interest of a child with slight ASD and learning difficulties be improved? We can put in schools with inclusive education. She's 6-year-old completed. What would help, like yoga or music or sports? Would yoga or music or sports help in increasing interest in education? Yes, Dr. Alok.
Yeah, see, yoga, music, or sports definitely will help you to calm down the child and to have the attention and concentration, all three. And as a result, it will help interest in education. Definitely, when the attention is better and child hyperactivity goes low, is able to concentrate and sit at one place. So definitely, education becomes better. So all three things, yes, not all three. You don't have to do everything at any one. Wherever the child is feeling more comfortable, we can go for it. Yes.
So yeah, I think that's it in the chat box.
One more request here. I see that somebody has requested for sharing some videos of cheeks and tongue movements for speech. Yes, I will do that with you. I have some videos, some material. So on your WhatsApp number, I will share that. Yes.
Thank you, Dr. Alok.
Yes.
So can you also share the detail about your center?
Definitely. Definitely. We are based at Vasco, and JKP Healthcare has another center which we are inaugurating in Mumbai, that is in Sakinaka, Balaji Multi-Speciality Hospital. And in Goa, we are based at Vasco. Vasco, right opposite to the KTC bus stop, we have child and newborn clinic. So we are based there. And in Mumbai at Sakinaka, we have Dr. Nishchal Shetty, and this center we are inaugurating tomorrow. So there are two units right now.
Good luck. All the best for the new center.
Yeah, thank you. Thank you. Any other questions from anyone? Otherwise, I think we will end up this call for today. And sure, Anu, I'll share.
For the videos.
I'll share. So
thank you so much.
Thank you very much. Thank you. It was really nice presentation, sir. Dr. Abhijit, first I thank him, and I thank all the participants for your questions, and it was like an eye opener for all of us. Thank you very much.
Thank you, Dr.
Thank you. Thank you,
Abhijit.
Dr.
Thank you,
Alok.
Dr.
Yeah.
Alok. Thank you.
Thank you.